Yeah, so let's start to quickly go through this and move on. This is a simple presentation, and usually, you'd get some multiple choice questions from this presentation, because it's simple, but it's quite important as well. So we've been talking about maternal mortality, a presentation that we've already had before, and how we've been trying to reduce the number of women that are dying, how we've been trying to reduce the number of babies that are dying in our labor wards from prolonged labor, from asphyxia, and so on. So the point is that once the mother is alive, leaves our labor ward alive, the baby leaves our labor ward in good health, that is not really the end. And in truth, it's not really a big achievement, because that's really why we are there on the labor ward, to make sure that mothers are safe and babies are safe. The women are coming to our labor wards or to our hospitals because they have trust that we know what we are doing. And sometimes they overtrust and we make mistakes and some of them die. But the point is that these women have confidence and they are expecting that they are going to go out with a live baby and the mother will be alive. But we need to go beyond that. We need to have women have a good experience when they are in our contact. It starts with talking to patients, being interested in their problems, not just as medical students the way we do. We just want to clerk for presentation. You're not really interested in the ailment of these patients. Sometimes a patient needs blood and you disappear and you run away, when you are getting history from the same patient to learn from them. So the point is that we need to go beyond just keeping babies and mothers alive. We need to be more friendly. We need to smile more to patients. We need to be humane when we talk to these patients and as we treat them. So that is really the point of this presentation. So the World Health Organization has found globally that there are a lot of different forms of disrespect that women face when they are under our care. And these kinds of disrespect are really universal. You are in Europe, you are in Asia, you are in Africa. There will be a lot of disrespect that are given in mothers that are in maternity care places. And they've highlighted and categorized these disrespectful kind of practices. So that's what we are going to talk about. So WHO, like I've said, have categorized like 7 categories of disrespect, which we are going to talk about. The first one is physical abuse.
Sorry.
Yes?
I can't see your presentation. I don't know, it's not showing.
Can
I'm
anyone
just seeing.
Is she the only one?
No.
You all can see?
Yes, we can see.
Okay, let me stop share first and share again. Anyone see anything?
Yes, I can now see. Thank you.
Okay, so we're just talking about the different categories of disrespectful care. And actually, people have found that the kind of care that women have can make them come back to the hospital or can make them deliver at home. So we know that even in Lusaka, 10% of, about 8% anyway, of women who deliver at home in Lusaka. If you go to rural places, Luapula, Northern, that number goes up to 30%. And people are saying that geographical barriers and things like that hinder patients to come on the ward, or to the hospital, but the kind of care women receive on our wards has a bigger influence than geographical barriers to getting to the health facilities. So it's something that we really need to look at and possibly correct. So the first kind of disrespectful care that has been highlighted by the World Health Organization is physical abuse. So the point of us talking about this is that if you see disrespectful care, you are coming on the ward for the first time or for the second time, if you see any disrespectful care, you're supposed to report it. Report it to the sister in charge, to the medical officer in charge, or whichever person is available, depending on who's causing this abuse. So you need to report these vices because they are not good. They prevent patients from coming to the hospital, and we end up having all these morbidities and mortalities that we keep talking about. So physical abuse is quite common. I have seen it. I have seen midwives pinch patients in the thighs, even doctors slap patients in the thighs, telling them to open their legs and so on and so forth. Those things happen. And when they happen, we are all supposed to say no. We are supposed to report, because next time it's you on that labor ward, on that laboring bed. And you are supposed to prevent these things from happening by reporting or by saying something. So that's the first thing. So no physical abuse. The second thing is non-consented care. Non-consented care is that you're giving care to a patient that you have not asked them, you have not explained the benefits, you have not explained the risks, and you are giving that care. It means that is non-consented care. You need to explain what you are doing, why you are doing it, the benefits of what you are doing, the risks of what you are doing, and then the patient needs to be competent. What that means is that the patient should have the ability to say yes or no. So a child can't consent. A psychiatric patient might not be able to consent. They might give a kind of assent, but they can't consent. So those are the things you need to say that this patient has really consented to the care that you are giving. So you cannot give somebody blood who has said, I don't want blood. You cannot terminate a pregnancy of somebody who has said, no, I don't want my pregnancy terminated. Somebody has severe preeclampsia. We've seen on our ward, somebody fits, they wake up, you tell them you have eclampsia, that's why you are fitting, you are very sick, and the patient just refuses to be delivered. You need to explain the benefits of delivery, the risks of delivery, and you need to make sure that the patient is able to understand what you've explained, and then you move on to deciding with the patient what needs to be done. You give them time. You give them time to process the information, because you are a healthcare worker. You've been doing this for 5 years, 10 years. So you think that delivery and eclampsia are a simple matter. But this patient is not a healthcare worker. They need to process what this disease is, what's going on, and it's hard to process those things. So they might need a bit more time than we would like. But the important thing is that we need to explain and decide with the patient what is needed. Then the other kind of disrespect that we see very commonly is non-confidential care and privacy, lack of privacy. So medical students, they get a history from a patient. They don't say that this history will be shared with other people. then they come and present. Even the history itself, it has parts. What are you really going to share to the other people in the history? So I was in a major round just a few weeks ago, and there was somebody who said, this is a para 4, gravida 5. She came in with bleeding, or was it spotting? And then they went on to develop the symptoms. And then they reached a point where they said, oh, this patient has syphilis, they have HIV, and their husband is not circumcised, in a presentation on the ward. And that is really getting into the personal privacy of the patient. And also the patient gave that information in confidence, because they thought that you want to use that information to help them. So now you come and announce it in a major round without saying that these are the things I will say in the major round, and you end up embarrassing the patient, and so on and so forth. So we need to be aware. And also, apart from that thing, there's also the lack of privacy. And this is also common in our labor wards, because you've seen our labor ward has 3 delivery beds, and really the patients can see what the other patients are doing. Our wards have more than 1 bed inside. So there's all these things that we have to think about and say, if we're in this position, would we be okay? And the point is not that lack of privacy and lack of confidentiality might be there. The point is that we need to spot it. You need to see it. If you don't see it, you normalize it, then you can't improve on it. So we need to make sure we are not normalizing these things about announcing histories of patients on a ward with 100 students, with 100 midwives, with 100 doctors, information that was given to one person in confidence. So that is about non-confidential care and care that has no privacy at all. Then there's non-dignified care. So what you see on the left is kind of a picture of somebody operating on a dog or a horse. And you can see that, you know, there's a theater light that is working. There's a view box with x-rays. People are scrubbed. People are gowned, operating on an animal. Not that we shouldn't be gowned when operating on an animal, but the point being that in what environment are our patients being taken care of? Sometimes you see a bed is not properly cleaned. There's blood on it, and then the other patient has to sleep on it or has to lie down on it. You see that this manual vacuum aspirator is not properly cleaned. You can even see blood inside the cannula, but you just put a blind eye and start doing an MVA on the next patient. This is really non-dignified care. Something people don't even do to animals. That's what we are doing to our patients. So we need to be aware that the care we are giving is non-dignified. How can a patient lie down on a bloody bed? How can a patient walk in the ward, labor ward, and there's blood all over the floor and you're offering them a bed? Things like that. Verbal abuse is also the other kind of disrespectful care that we see on our labor ward. I always give this example in giving this lecture of people trying to do a vaginal exam on a patient and them saying that the penis which went in when making you pregnant is much bigger than the cannula that we are using, or my fingers are smaller than the penis that made you pregnant, especially when they have a young person. Can we please mute? Especially when we have a young person, we see a 14-year-old, our tone changes when we see a 14-year-old in labor ward, when we see a 15-year-old. Yeah, so our tone changes and we speak in a very disrespectful manner, like we are the parent to that child or a guardian. When a patient comes to the hospital, we are not the parents and we are not the guardians. We are not supposed to teach morals to patients on the ward. We are professionals, we are taking care of the health of the patient, and that's what we should stick to. If we move away from that, that's really non-dignified care, and most of it manifests as verbal abuse. Then the next one is discrimination. So we've just done non-dignified care and verbal abuse. The next thing is discrimination. And this is quite common as well. I've just given an example of you seeing a 14-year-old on the labor ward and your tone just changes. The way you speak to her just changes. You're not respecting her. You're not speaking the way you're supposed to speak to her. So that is really not the way we should be speaking. When we see that it's a politician's daughter on the ward, people are scampering, people are calling consultants to come and see the patient. Every patient, whoever they are, should get the same kind of care. Young, old, Muslim, Hindu, black, white, yellow. Everyone should get the best care that they should get. We shouldn't be scampering when somebody comes. We look at them and then everything changes. Suddenly the lab tests have appeared. Suddenly there's blood and so on. That is a kind, discrimination is a kind of disrespectful care. So that, I think the point is made there, we can move on. Abandonment is also quite common, especially in those patients who refuse an intervention. We've already talked about consented care, how a patient should get consent. We should get consent before we go to theater. We should get consent before we do an MVA. We should get consent before we do an episiotomy, all those things. Now, when a patient refuses, that's where you see a lot of abandonment. Sometimes a patient refuses to be delivered and people stop doing blood pressures because this is a severe preeclampsia that has refused delivery. People stop doing blood pressures. They just ignore the patient and so on and so forth. There's a way to manage a patient who has refused something instead of abandoning them. There are alternatives. For instance, a patient with PPROM who's refused to be admitted because they are 28 weeks and they might need to be on the ward until they are 36 or 37 weeks. They're saying, no, I need to go home. I can't stay here. But we know that in our, the way we treat patients with PPROM, we admit them, we give them dexamethasone, we measure the pad count, we do surveillance for chorioamnionitis, and so on and so forth. So we are not happy. We do temperatures every day. We are not happy for them to go home. Or patients with placenta previa, we are not happy with them to go home. But there will be that patient who will say, I can't be here from 28 weeks to 37 weeks. It's better I go home. So, you know, there's a way to manage a PROM at home. So just say the benefits and the risks. If they can take temperature at home, they can do a pulse, they can do a pad count, they can check their fetal heart. Yeah, give them a list of a way they can be managed at home. Even when they refuse, there's nothing that we can do. The hospital is not a prison. The hospital is a hospital. So the point we are making here is that you don't close care because the patient has refused your treatment. That's the point that we are trying to make here. Don't abandon the patient. Get a phone number and say, oh, okay, you're going home. We've understood. If there's need to sign, they sign somewhere that they've understood the treatment, they've understood the benefits of going home, the risks of going home, and they are ready to sign for it. They go home. You can even get a number, their phone number, and you know, every day try and call them and say, how are you doing? How are things happening? Because the care hasn't stopped because the patient has refused your intervention. This is spilling over to this point. It's the same that we have just said. The detention is a kind of disrespect. You can't detain patients in the hospital. If a patient wants to go, explain why they need to stay, explain the benefits of them going home, and let them go home when they want to go home. If it's really a critical patient, a patient you need is risky to take home, they need to sign somewhere. If they can't sign, maybe a witness or a relative can also sign that they've agreed as a family that this patient should go home. And involving other people. Don't just, a patient wants to go home quickly, they go. You just say sign. Involve another person who will explain to that patient what's going on. Maybe they will understand from another person. So get another person to explain what's going on. A third person maybe before this patient says that they want to go home. So that all those things are documented, that several attempts were made to explain to the patient what's going on. And this patient insisted on going home after having understood what was going on. So the point is that we cannot detain patients on the ward. The ward is not a prison. And if a patient wants to go home, they can really go to their home as long as they've understood what's going on. So we've already talked about that disrespect has a big impact on our care for patients. I've already talked about this. And this is really a summary of the 7 categories of disrespect that women face when they are on our labor wards. The point is that we should not normalize them. That's the first thing. We should be able to spot these disrespectful practices. Second, we should be able to report them to a supervisor when we see them. And thirdly, we should not practice them. It's not worth being mean to someone, being bad to someone. Just imagine that next time you are the one who will be on that table. The same table that is not being cleaned properly before someone goes in is the same table that you are going to use when you need surgery yourself. So we need to be aware that the same facilities we are working in are the same facilities that we will be treated in. So if we create a practice, a culture of disrespect, that same thing is going to happen to us when we come to the facilities. So that's a summary of the disrespectful practices that are there. And I think that should be the last slide. Yeah. So that's be nice. It's a small world. Your patient might be your supervisor next time. Yeah. So thank you so much. I don't know if you have any questions. That has been like 24 minutes. So in the next 4 minutes, if there's anyone with a question, we can ask and then close and move on and do other things. Anyone? Anything, something you, yeah, go on.
I have a question. How do you talk to someone if maybe, let's say, they are a senior doctor or a consultant and you see them disrespecting a patient? How do you go about it? Do you just approach them, even as a student, like despite them being a consultant, for instance? How do you go about that?
A huge question. I was actually thinking about it when we are talking about it. But you know what really kills us as Zambians? We don't speak. We see a wrong thing, it goes on for 10 years, and we don't say anything, and it keeps escalating and escalating and escalating. I understand your point that as a student in that situation, and even as a consultant, me here, a fellow consultant, does something disrespectful. It's because of our culture, it's really difficult. Unless somebody's junior, it's very easy. But if somebody's senior, it's quite difficult, but it's something that we have to fight to do. I think everyone has a supervisor. What you might need to do is inform a bigger supervisor to that one. So you could go like to head clinical care, leave a note, and there are those suggestion boxes that are put in the hospital. If you've seen something not right, you put there, and there are people who open them in confidence, and they try and look at them, and they take them to clinical care's office, and clinical care does something about it, something in those lines. But I get your dilemma and where the problem is. Yeah, but everyone has a supervisor, and you could drop a note, even an anonymous note, to a bigger supervisor for that a person you've identified who's done something disrespectful to a patient. Yeah, but I understand how difficult that is. Any other issues, something you didn't know? Something you didn't know, something you've learned? Just a comment before we close. Yes? Is somebody talking? Hello?
Doc, I've got a question.
Yes, ask. We have 6 minutes before.
Okay, so in an event
where
you have a child who is less than 5 years, and that child has severe anemia, then on the full blood count, maybe you discovered that maybe that child has an HP of 2 grams per deciliter. And then the parents are Jehovah's Witness.
Yeah.
You decide maybe to make a decision of transfusing, and then the parents reject, they opt out to that decision. What do you do in such cases?
Yeah, that's also a good question that I normally get. It's a very hard question. Firstly, because the child cannot consent, like we said. For you to consent, you should be competent, meaning that your brain should be at the level at which it understands what is going on for you to be able to consent. Otherwise, you cannot consent. That's why people say you cannot have sex with a less than 16-year-old, because they can't consent, because they are too young to consent. They're not at the level at which they understand what's going on. So this is where that question is very difficult, because when a parent cannot consent for a child, then it means that we are stuck. But I've seen people take a step of going to court to get something to allow them to transfuse, and it has been done before. If it gets to that point where it's difficult, after you've explained and you are stuck, I think that people have gone an extra mile, talked to head of hospital who has asked the court to intervene for you to get in. But I've also seen babies die. Even a doctor's babies die because of course, the doctor is a Jehovah's Witness, and they've refused blood on their child who has some abdominal cancer. So religion is very difficult. And most of the time what will happen is that if you insist that the patient gets blood, you just find that the mother is not there, the baby has gone home. They've abandoned, they've left the facility. So that is what usually happens, but that's the extent. Head of hospital, and then head of hospital can go out if you have that amount of time to ask some authority bigger than the parents, which is usually the court, to intervene in the affairs of that child. Yeah, if it's an emergency, usually the child dies, there's no time, because the parents who are the custodians of the child have refused to allow you to intervene in the patient. It's like a parent who refuses surgery on the child. It's very difficult to do that surgery. Yeah, you probably need to involve relatives before you even go to the head of the hospital. Try to talk to the relatives to convince that patient, and then you can go to the head of the hospital, and then they can escalate it in another direction if it's not done. Yeah. Okay, so yeah, there are no easy answers to that question. Is there any last question? Somebody should say no questions, then we can go.
No questions.
No question.
Okay. Okay, thank you so much. We'll meet another day.
Thank
Thank
you,
you.
Doc.
Thank
Thank
you,
you.
Doc.
Hello. How are you? Fine, fine. Or the Caesar set, yeah. It's just in the open. Unless you people sort it. Yeah, on top of things. Yeah. Or fistula things, your fistula things or my fistula things? Oh, because the set is in a kidney dish. Okay, so just check for maybe some surgical instruments there or something. I think there is something that belongs to me there. No, I don't